Welcome to the Finding Financial Freedom podcast with the Frugal Physician, where Dr. Disha Spath will be your companion on this exciting financial adventure. Get ready to conquer debt, build wealth, and embrace a mindful spending lifestyle that will empower you to live life on your own terms.
Hello, and welcome to Finding Financial Freedom with the Frugal Physician. I'm your host, Dr. Disha Spath, here to help you navigate the path to financial independence. Today, we're going to be resuming our interview with Dr. Josh Umbehr, the founder of Atlas MD. He's here to tell us more about direct primary care and all the other amazing things going on at Atlas MD. So welcome back, Josh. Now, there's so many interesting things that you've said thus far that I really want to dive into, but I want to talk to you about your Atlas MD. You set up Atlas MD as a EMR for DPC doctors, and you started that as well, right? So tell us a little bit about that. Why did you feel the need to come up with a whole new EMR for DPC?
Yeah, I feel bad. Like George Foreman named all of his boys George. And so we've got a clinic atlas, we've got an EMR atlas, and December we launched a health insurance company called Atlas.
Right.
So I like the name.
Wait. First, why do you like the name?
So a big fan of Ayn Rand and Atlas Shrugged.
Yes, I was hoping so.
I remember reading it in med school and on rounds on a little old brick phone and getting tricking attendings into giving me reviews because they always saw me reading. Oh, so studious. I read medical stuff. I mean, I'm not a bad doctor, but I was hooked on that book like a lot of people are. And it rang true, I think, in lots of ways I could talk about. But yes, the clinic was something I dreamt about for so long and tried all kinds of names. And then once I realized you could buy a website that ends in .md, thank you, Moldova. Then it's like, oh, that's it. I'm hooked.
Love it.
But,
yes. I was just talking to my husband yesterday about how, but being an internal medicine or primary care doc in this medical system feels so much. I feel like Dagny Taggart, like trying to just save the system from crumbling. And I'm like the last one working and everyone's falling out. and there's just like so many pieces to pick up in our broken system. And says to me, the only thing you can say, Disha, is who is John Galt? Because that's like the only way to get through.
That's it. No, you're so right. I heard somebody talking about what it's like to work for one of Elon's companies. And the thing that struck me was they said, you're dropped into an insane level of competence. And I thought, oh, that's interesting, right? Because I feel like everywhere in healthcare, the system benefits from not being competent, right? Oh, we have to keep you on hold. You can't do this digital. We can't tell you what meds we approve and why, because we're afraid you'll game the system. Like it's intentionally slow. That's on purpose and in the system versus at least here we can aim for competency and stuff. So yeah, I mean, you're working in a world that's working against you most of the time.
Right. So now let's get back to making it work for you because you're doing that. So let's talk about that EMR. Why did you come up with the EMR?
So in the first 6 months, speaking of which, we opened September 2nd, which of course is the date the book starts. So we try to blend that throughout.
Wow.
Open September 2nd, and by April, we had 9 different software programs that were, wouldn't talk to each other. Something for calling, texting, emailing, scheduling, charting, faxing, inventory, billing. My poor wife / CFO / nurse was doing QuickBooks in the basement. It would take generally 5 hours per 100 patients, which is fine when you started with no patients, right? But it was not a scalable system. And so come April, we have, maybe 300 patients, and we were spending all day just moving paper. You couldn't print meds without turning the Xerox to one drawer, and then you couldn't print shipping labels without going back to it. And it was just slow. But that was fine because we were learning it. We were handwriting labels for prescription bottles until we found out that was illegal. But then we'd print an Avery list of labels that were mostly filled in with text and then handwrite the rest. So we're constantly kind of progressing forward. We knew, hey, just jump and build the parachute as you go down. And So in April, we went to a team and said, hey, if you can just combine a couple of these things, that'd be great.
Mm.
And Gilligan's 3-hour tour turned into, going on 12 years of software development. But we built it for ourselves for about 18, 20 months before we had enough doctors visiting our clinic on a regular basis, learning about direct care for themselves, trying to, figure out solutions to burnout. And then, okay, but now functionally, how would I go do it? Well, here's the list of the things we did before. You can use these or something else, but we knew that would be hard. So we kind of were lucky to be in this so early that we could start that real slow on all the boring stuff. And now we went from one part-time programmer a month to over 30 programmers, a whole team, 5, 6 sales and support guys. It's really kind of wild. So it's a labor of love, but yeah.
Wow. Sounds like you're going to be solving a lot of problems with that. How much does your EMR cost?
$300 per doctor per month, and then all staff are free.
Okay.
All training, all support, all upgrades are free, and we have the lowest credit card rates in the industry as well.
Awesome.
So yeah.
Awesome. Okay. And now let's talk about the health insurance that you just launched. Tell me about that.
So I would say our main goal is to grow direct care as much as we can. We can't grow it fast enough. If we were adding 1,000 doctors a month, it would still take 100 months to get through, a good chunk of the American Academy of Family Physicians membership, right? Let alone everyone else. This has to grow much faster. And we're probably in the ballpark of 35 to 50 doctors a month system wide, which is great growth because, again, it used to be none or one or two. It's rolling. So everything we do is around that thought process. And the big question we always hear from patients and docs and people exploring direct care is, how does this work with my health insurance?
Mm-hmm.
Right? You've got two big pieces of the puzzle, healthcare and health insurance. And if you design one really well, you can design the other. We launched before the Affordable Care Act was in place. So we kind of launched under our ideal setting where you could go to an insurance broker and say, I want to spend this much per month on insurance. And they'd say, great, what do you want to put in or carve out? And like, well, we got direct care, so we don't need primary care. We've got meds, labs, urgent care covered. We've got, some ER, et cetera. And you could get down to something very affordable. Then the Affordable Care Act came out, and really we only had that option with employers. That was still fine. It grew very well. In fact, I'll joke, the more broken the system is, the better for direct care, right? Because doctors get frustrated faster, patients get frustrated faster. $25,000 per household per year. A slight sidebar. What's so wild about that is we met with Walmart. They invited us to come out to Bentonville in 2012. And they have this on a RFI from November 2011. They predicted the average cost of health insurance by 2025 would be 25,000. So like they nailed it, right? It's going up basically $1,000 a year for an employer per family. Just unaffordable, right? I mean, people used to make 25 grand a year. Now you have to
Right.
spend 25 on insurance. So it's suffocating everything else. And Sean Flynn, one of the founders of the health insurance, is a fantastic economist out of Scripps College and wrote a book, The Cure That Works. And among other things, outlined that the statistical best country is Singapore because it's heavily market based with a little bit of government influence. And then countries like Canada and the UK that we think about for universal healthcare wouldn't rank in the top 10 for cost effectiveness of years life and healthcare and stuff.
Yeah.
More importantly, though, he said, here's the size of the budget. Here's what you could do if you fix that, right? Basically, where could you spend $2 trillion? Well, you could double or triple the size of the, education department, Department of Education, military budget, medical debt, socio economic things that cause healthcare issues, anything. I mean, $2 trillion goes a long freaking ways. And you could do that just with the waste in the system. So we at least had lots of great options and still do for employers to go in and say, great, we can carve our insurance back, wrap it around direct care, and save 30 to 60% on the first year. And those savings usually get better over time. And if nothing else, less administrative costs, less nickel and diming, but also the direct care model is pre-shopped, Costco style. Like, hey, great, here's the meds at the lowest price you can get. Costco or Walgreens buys them for less, but they'll never sell them to you at less than what we get them for, right? Costco or Walgreens would have to entirely change their business model to be able to outcompete little direct care doctors dispensing meds. Worst case to best case scenario for Topamax is one example from a list of seizure meds. Walgreens is over $108 a month, wholesale from direct care practice, cash out the door, $1.32.
Wow.
So,
That is
so
quite
why
the
are we
differential.
insuring that? Yeah, it's,
Yeah.
for a migraine or a seizure med or something, we don't need it. So great. That's what business is good at. Doctors should proudly embrace good business. So then you don't need to insure that. And then copays, because we don't have copays, that's 30% of just what insurance pays is just the other half of that copay, right? So you're saving the patient the copay, you're saving the insurance the copay. Great. If we just made health insurance 30% cheaper, that'd be amazing. That'd take us back to almost 1990s levels, right? But now, grant, 80/20, you can't fix every copay because some of those are specialists or whatever. That's fine. But, 30% on copays, 10 or 15% on labs, 34% on prescriptions, 10% on ER visits, et cetera, decreased hospitalizations, urgent care, ER. Now you're really playing with serious math there where what's left to insure? Statistically, not a lot, because so much of that care is able to be provided in more cost effective ways. We're not saying eliminate ERs, we're not saying eliminate urgent cares. Yes, there's expensive meds, but where doctors get really bad at that math is, yeah, but what about? Yeah, what about? There's more money spent on statins every year than on MS meds. MS meds are crazy expensive, but for such a small population that you can insure that, that's somewhat easy. The difference in the cost of what Medicare and the patient pay for Lipitor, the number one at the time we did this study for number one medication Medicare paid for, we could save $1 billion to Medicare Part D on one medicine. So that comes out to about 1% of their $99 billion a year budget. The next 40 best meds would save another $20 to $30 billion. This, like Granddad used to say, $1 billion here and $1 billion there. Eventually, it's real money. And so now you get back to a reasonable model of insurance, rare things. And if people struggle with this concept of how do I afford my insurance and the direct care membership? Great question. We'd reframe that as how do you afford your insurance without your direct care membership, right? Because we can pull so much. We all agree insurance is broken, right? It's really interesting Stockholm effect that Canada and England and the US do in opposite ways of both know the systems are broken, but neither want to change because somewhat connected. Like, oh, I know healthcare is broken, but it's not 95% broken, is it? Like that feels too good to be true. No, it is. It's 95% broken on a lot of meds, right? On EKGs, on stitches, on biopsies, on MRI machines. Yeah, most things generically 80 to 90% less without insurance. That's unbelievable because we were told insurance decreases the cost of things. And so for us to say, all right, what's the next big thing that direct care can tackle? We did unlimited visits. We did free telemedicine. We were doing video calls for years before COVID kicked in. Wholesale meds, wholesale labs, wholesale consults, wholesale imaging, wholesale DME. You eventually, okay, now's the time we say, the next big thing we can tackle is insurance, health insurance for direct care clinics and their patients only, because it wouldn't be good insurance if you weren't with direct care. Those two things combine, but I also don't have life insurance that pays for groceries. I don't have home insurance that pays for yard work. Those things
Right.
are automatically affordable or already. So getting to a common sense there where when you carve all that out, you're insuring much less, which is kind of wild to tell people is the answer to affordable insurance is to not use insurance, to have less insurance, less coverage, but the right coverage.
Right. Yeah, because I think people went into insurance thinking, well, I'm going to have to pay for less. If I'm paying an X amount per month, I'm going to be insured for everything. And you're kind of doing that, but then putting that X amount that they're paying a month more at the people that are actually going to provide the value, which is primary care, and keep them out of, and then the catastrophic things that happen or get insured at a lower monthly rate, I'm guessing. Now you're going directly to employers. So you are selling this insurance to employers then to then have to work with DPC practices?
I mean, employers have lots of options, this included. This would be for individuals, families, and employers. So we're licensed in 13 states, and it's, again, our vision for what insurance should look like, where the money goes to the patient, right? And then the patient can pay the system, but now they have the power there as well. But also, when the patient pays the system, they qualify for self-care, self-pay. And when you're self-pay, thanks to previous administrations, you are afforded the opportunity for significant discounts. I know our hospital locally in HCA chain on their website, self-pay patients in the ER are eligible for a 92% discount.
That's insane.
It is insane. It's insane to us, and we're doctors. It doesn't make sense. No one in the world, if Best Buy tried to say, there is a 92% discount, but only if you knock, if you know the secret handshake, it'd be ridiculous.
Yeah.
But yeah.
So, okay. So the patients that have Atlas MD insurance are qualified as self-pay when they go to the ER and hospitals because it's kind of an alternative insurance.
Yes. So it's not health insurance at the federal level, which we did on purpose, because if you were health insurance at the federal level, you'd have to comply with the Affordable Care Act, minimum essential coverage, all the things that then raise the price of it. And that we're trying to be smarter about it, not the same way about it. So then that makes it expensive, and it doesn't have a benefit to direct care. But it is licensed insurance products at the state level, which is sort of a wild thing in its own right. For us being the no insurance guys for so long, now I'm a licensed insurance agent in 13, 14 states, and growing. So then it's regulated, the finances, the risk pool, the actuarial math, all, approved by the states so that this is legit, and you have to pay. But because it's a different type of insurance, what we call supplemental insurance, you can think about it like Aflac. It's known as a fixed indemnity product, which means a fixed payment price. The benefit to being new and different is followed with the restrictions of being new and different. Fixed indemnity products are everywhere, but we have to say, okay, for a colonoscopy, what price do we think we're going to pay that might be fair across the country? So you can see this in our schedule benefits based on the CPT code of colonoscopy, screening or not screening, or screening or diagnostic, $1,500. The problem with that is not everyone knows what is a good price for a colonoscopy, right? But in general, and there's a great website, Colonoscopy Assist, locally it's between $900 and $1,200. But our patient would still get the $1,500. They could make money getting their health care. That's this working out very well. They could also have to pay 16, 17, 18, on top of $100 or $200, $300. So it motivates physicians to have transparent prices. It motivates patients to find those transparent prices and for us to help them do that. And then it also motivates doctors to have a lower price, because one price is good, but a price that allows the patient to have extra money, even better. Right. And what we're really hoping to eventually get to is this, kind of model where there's the potential for patients to make money or lose money. Well, you got to be very careful when you're a licensed insurance agent. But Dr. Paul Thomas, Plum Direct Care out of Detroit, had a great Facebook thing that went a little viral and showed a patient's bill, and $100,000 craziness. When you factor in even a 50% discount, if those patients were using our insurance, they would have made money, right? And several thousand. So then you could go to the hospital, get your care, get your discount, get your money, pay the hospital, and have a little left over. That's wild. right?
Yeah.
That's too good to be true. It may not happen that way every time, but we only launched in December. Actuarially, we do hope it does happen. We expect it to happen, but it's the way insurance should work. That's why Aflac's so successful. Then you don't have to worry about deductibles, copays, networks, right?
Mm.
The patient doesn't have a deductible. It's if this CPT is on our list, then you're covered. We have a hospitalization rate at $3,700 per day. The first day, the admit day is, I think, $1,500, again, in our schedule of benefits. But the national average is $2,800. So then, again, the patient could make money. Now you hear $100,000 for 3 days in the hospital. That's the problem with healthcare is all these numbers are so inflated, and then people feel like the system is scarier than it is, unfair, broken, not looking out for them. So it's a big lift to educate doctors and patients and hospitals and say, we're aiming for this moonshot of what healthcare should look like: transparent, affordable, reasonable insurance, and then more care more often, faster and easier and cheaper.
Here's a question. What's the true cost of not having a plan for your finances? With Facet, you don't have to leave that to chance. With their flat fee membership model, Facet is building the future of financial planning. You'll get access to a team of certified financial planner professionals and guidance across tax planning, estate planning, and more. No commissions, no hidden costs, just expert advice that evolves with you. Take the next step in securing your financial future and check out which membership option is right for you. Visit facet.com/frugalphysician today. That's facet.com/frugalphysician.
Wow. I mean, I got to say, even as a healthcare provider that, is very well versed in finding pricing, hospital pricing on things and, looking up different, I usually look up like what costs the least. If it's going to be an elective procedure, I'll go and look up, okay, which hospital is providing the best value and, and that kind of thing. But I can imagine this would be very stressful for a patient to think that I could get like a total cash bill from a hospital and be on the line for that. But sounds like you're doing fantastic things. I'm like so inspired by how you are fixing every single piece of the puzzle of healthcare and delving into these really scary topics. Now, I want to get back. I know I've taken up a lot of your time already, but I want to get back to the doctor who is DPC curious and is really inspired to start looking at an alternative way to provide healthcare. Let's get back to what would you tell them if they wanted to start a DPC practice? First of all, the structure for their practice. Would you say for-profit or non-for-profit?
That structure is probably essentially the same. I like to lovingly say direct care isn't profitable enough to attract like VC interest, which is great. There's a graveyard of clinics trying VC-based direct care, and they can't work because they have to make it more expensive to make their
venture
revenue.
capital, right? Yeah.
So essentially, anything left over after nurses, rent, EMR, malpractice, lights, Wi-Fi is profit. That goes to the doctor. And then whether you're for-profit or nonprofit status is a bit moot in that sense. Jumping through the hoops required for a full nonprofit status might be more than most docs want to do. And so they're not limited. There's no specific tax benefit to make that worth it more than something else because they're not scaling up to hundreds of doctors to change that math. Most direct care clinics are still going to stay in that small niche. So.
Okay. All right. And then how much can they expect to make?
I advise docs to aim for top quartile, right? But not top decile, right?
Okay.
The pricing and money is the hardest thing, right? I'm sure that's the topics you covered.
Right.
And we haven't run a business before. We're coming out. There's a little bit of a, oh boy, what could I do when I'm running it myself kind of energy. And then comparison is the thief of joy. So we start looking, well, what's the highest price I can find somewhere else and I'll charge that, right? But that's such a limited amount of information, and it's also counterintuitive. So we offer all of our consulting free of charge to anyone interested in direct care. Doesn't matter if they use our software or not. We're trying to grow the movement. So we have a free lawyer, a free pharmacist, a free cardiologist, and a free radiologist to help direct care doctors, right? And part to show the value. Like, look, there's a lot of unintuitive ways that you can add value and bring that over to your clinic. In that, it's easy to get bad advice or be attracted by bad advice, which is often around pricing. And Dr. Doug Farrago, DPC News, best probably DPC lecture in a long time, did one this summer on failure of clinics and why. And there's lots of reasons, but a lot hinge on, bad pricing and bad marketing is going to fail. Bad pricing and great marketing is probably still going to fail because you're still selling something that's very high priced. Low prices and bad marketing works. Low prices and great marketing works, right? So we're trying to make it as easy as possible on yourselves. And it is counterintuitive that higher prices make less money, but only when you're thinking about it from your perspective. If we put ourselves in our patient's shoes, a customer's shoes, with that empathy, then it's obvious what to do. I like to say physicians are trained in the pathology of psychology, not the application of it, right? Lower prices are going to, I don't want to be devalued. I don't think that would be the case, because then you'd be asking the American Academy of Family Physicians to raise their dues every year just to make it more valuable, right? You'd be asking your malpractice to charge you more. You'd be asking restaurant, well, this is way too valuable, you should charge, right? When we're the provider to a consumer product, we see that as, higher price, higher value for us. And everyone will agree. When we're the consumer to a product, we want the best possible price and value. So it really helps to look at it from that point of view. But also there's an amazing book, Risky Business, Why Insurance Companies Fail and What to Do About It. And it's selection bias. So, pricing is a big topic, but real quickly, the higher the price, the fewer the people who see that value. If I need $1,000 of care per month and your prices are $200 a month, that's a steal. But if your prices are $200 a month and I don't go to the doctor often, I'm not on meds, I don't need labs, that's not a steal, right? So those people peel off sooner. The sicker people stay on until it's more than they can afford. It ends up hyper concentrating your risk pool. Insurance does this all the time. Harvard did this. Harvard made this mistake 3 years in a row, and the book talks about this. The counterintuitive part is lower prices get more people in. You need enough healthy people diluting that pool so that you've got people who don't need you as often and people who need you more often, but you don't know who those are going to be. So if you set your prices right and you fill up, that's the number that matters. How fast do you grow? If you don't make any money the first year, well, you're going to have to make 25% more for 4 more years to catch up to the lost revenue. Well, but you didn't make any money the first year, so you're not going to get full all of a sudden in 1 year, right? So it's financial suicide to set your prices wrong, because you could set your lifetime earnings back a decade by doing it. But also the motivation of direct care isn't for the doctor. It's for the patient. Is how do we fix healthcare? We make our money by helping patients. We have to help enough patients. We have to work hard enough, right? Like there's a sweet spot to this math where we see docs come out and say, well, I get it. It's PTSD, it's burnout, it's a decade of feeling disrespected and untrusted, it's post-COVID, it's all these things. So they come out and say, well, I think I'm going to try to see 200 or 300 patients, but I want top decile or more than what I could get out in the market. Well, that's hard because the market is based on what hospitals are charging, right? They're going to be able to pay you the most, but they're going to ask the most in return. You got to see the most patients. You make more if they have great insurance. If you maximize your RVUs, you order more, bill more, do more. Sure, and they charge more for it. That's a system that can pay the most. I don't think docs should be a martyr here, but they have to realize where that math is a sweet spot, a win-win for them and the patients. You do that, you knock that out of the park, you'll do wonderful, right? And then seeing 600 patients, we only see 1% or less a day in the office, right? This whole thing is more efficient. I haven't written my own note in 2 years because of AI, right? And so I chart 5 minutes a week, but I only see 3, 4, 5 patients a day in the office. That's the point. So now if you wanted to see 100 more patients, well, that's just 1% more, one more patient in the office per day. And there's calls and texts and emails. But even at our prices, another 100 patients, it's another 50 or 60,000 a year on top of your overhead that's already covered. So, that's gravy.
Yeah.
You can make more money, but you still have to be fair to patients. You just might have to work a little more, or, my overhead's high. Relative to what most doctors have, just because we have an expensive office. Most docs don't need that. So that's 50 to 75 patients extra that they may not need. So there's wiggle room there, and we go through the math with them. But I think that's the hardest part for docs, that are curious to say,
Yeah.
what do I do? How do I set these prices? What's it look like on a day-to-day schedule? What hasn't worked, right? You
Mhm.
can see open clinics, but you can't see their numbers, how fast they've grown, how much it took to get there, yada, yada. And you can't see anything about clinics that close and their websites aren't open and they don't talk about it and they don't share. And a lot of closing clinics struggle to understand why they closed, right?
Yeah.
But, one clinic I can think of, everyone says, well, I live in a high cost of living area, so I'll charge more. No, that's counterintuitive. High
Mm.
cost of living area does not equate to high disposable income area, right? Those are
Right.
different things.
Yeah.
So everything is expensive there. You have to be just as smart about those budgets as anywhere. So adjust your rent, adjust your staff, adjust your things to accommodate that. But so one doc on a coastal city opened 10 months. I'll rough out the math so it doesn't match their website. $300 a month membership fee and a $300 a month enrollment fee. Well,
Wow. That's a
that's
lot.
very high. That's a lot.
Yeah.
Yes, it's a lot. And so 10 months into it, 7 patients.
Mm.
You won't get nothing, but everyone, the scary thing is you're wholly responsible for the advice you take from other people. And I say, if they haven't opened these practices before, if they're not going to pay your mortgage, if they're not going to support you when, if it doesn't work, then you got to be cautious about that advice, because there's a great book on this, Radical Candor. We're sort of really good at just cheerleading each other, not saying, I don't know if that makes a lot of sense, right?
Mm.
If you're just doing weight loss, you're probably a pill mill. If you're just doing hormones, look, if you're following good standard of care guidelines, you can probably, most docs are going to provide that, right? So your patient population doesn't need just one thing. And I don't know how you do weight loss without doing depression, anxiety, diabetes, blood pressure, cholesterol, osteoarthritis, body image issues, et cetera, to just
Mhm.
do one thing. And so, because that's the most common thing we see now that fails. So you have to have a full approach to doing this. It can be very profitable and very rewarding and very hard, because medicine is hard. I joke, patients are the hardest part about this system, but it's
Yeah, I
worth it
mean,
too.
yeah. Doctors, I think, are not scared of hardness, right? We're not
No,
scared of working hard. It's more about, work-life balance too, I guess. So let's talk about that. How do you manage, as a DPC model, you're kind of giving patients your cell phone, right? And they can reach out to you at any time. So how do you manage that? Do you get a lot of calls after hours? And how do you manage being on call 24/7?
I think it is easier than anything. So I probably have 670 some patients myself right now. The longer they're with you, the easier it gets, right? Then they understand calling and texting and emailing. Great staff who use the model to its fullest. A patient will call and say, hey, I need an appointment right away for pink eye. Great. Nothing's faster than texting the doctor a picture of your pink eye.
Hmm.
Right. And so then it doesn't have to be an appointment. But if you're not leaning into the models, text messages are free. Office visits are still free. You can have one or both, right? But hey, it's 7 a.m. Text me a picture of your eye. Don't wait till 9 o'clock, and then I can look at that and be like, hey, that doesn't look terrible. Send me a picture again in an hour. And that's the psychology of customer service a lot, right? The longer they have to wait, the more anxious they get. But
Hmm.
also, I don't have to chart that. My dictating through Siri, my response to this, I takes 30 seconds, because, we're trained doctors, but it goes right to the EMR. So it's 30 seconds of work and I'm done.
Wow.
There wasn't a whole lot more to it because you're not billing insurance. You're not documenting. They're with you. They're going to keep, again, text me every hour until you get bored with that picture. You couldn't do that in an insurance model. Too cheap to insure. Too cheap to schedule. Yep. Because you're not just going to come back to my office every hour. But yes, it doesn't look bacterial now. Most don't need antibiotics, but it might look bacterial later. Peace of mind, keep sending those free, pictures. But also charting takes less time. But I can spend more time with the patient. Again, should feel too good to be true, but most of our appointments go 30 to 60 minutes, but take less than a minute to chart because of AI and we're not billing insurance. So that part's better. But also, that's one reason you don't have 1,000 patients in this model. Sure, you could make a lot more, but then that work would spill out into those nights and weekends a lot more often. But they don't have my actual cell phone. They have a phone number that's based out of the EMR. So it's why it syncs with their chart, but I can forward that on to my partner for vacations or anniversaries, etc. But 600 seems to be a sweet spot where, you may get one or two text messages after hours, but it's not a ton. And that's what they're paying for on some degree. Like, yeah, that doesn't look bad, but we can, here's the link, schedule in the morning. Or sure, no problem, I'll mail your meds in the morning. Rash doesn't look terrible, right? You're not having a whole annual visit after hours. You're managing just those acute things that actually save them a ton of money and hassle. So that work-life balance, I think, it's better now than it was in residency when you had a pager and a hassle and charting and covering for another doc, so that doubled your patient panel size, et cetera. So knowing your own patients and all the other efficiencies, I think makes it pretty good.
Nice.
Yeah.
And how much should doctors expect to pay for their overhead? I know this is a tough question, but just let's break it down. How much should, just ballpark, the malpractice insurance cost?
You should be able to get less, of course, right? State dependent and practice dependent. But in general, we recommend groups like NorCal and other groups have started doing this. But if you ask for either just now direct care malpractice, more understand, or tell them your direct care and ask for part-time malpractice rates, because they've always done this, what we learned originally. They had offers for part-time, like, yeah, I do 1 day of urgent care a week. Less patients seen, less risk. Well, we're in the office full time, but our patient volume is part-time. And they also like the benefit of no copays because that's a barrier to the patient getting more care. And so they're going to wait longer for that abscess or that chest pain thing. They also like the communication syncing directly with their chart. Yeah, you said left-sided chest pain, jaw pain, swelling, nausea, or sweating, nausea. Yep, I told you go to the ER. I told you go stat. I told you, at this time and date stamped several times. Those kind of things all help, but also just the evidence is clear. Happy patients don't sue, right? It's weird to talk about, but it's true. Well, when you can focus more of your time on the patient and build that trust with them, and they know, again, your meds are transparent, your labs are transparent, your procedures are free, we have your cell phone, we know that you're available and you're trying and you're not trying to blame insurance or skirt the issue. I think that goes a long ways. So malpractice 3 4 5,000 a year compared to a lot more. So ballpark half. I would say it's hard to say a percentage because some docs would try to do a micro practice with no staff or 200 patients for 600. So on 600, I'd say one staff member per 1 to 2 docs and rent is going to probably be 80% of your overhead. And then fold in malpractice, EMR, Wi-Fi, phones, little stuff like that. So that gives you a rough number. Like, okay, well, am I going to hire a full-time RN? Am I doing 1 or 2 part-time MAs or an LPN? Can I give them flexibility and they get to leave at 3, so I pay less, et cetera. So there's ways to adjust that overhead accordingly. I know docs in rural towns. My rent's $6,400 a month. They have a rent of less than $1,000 a month. So again, that comes out to about 100 patients a year less needed to hit the same financial goal, or you're making that much, 60 grand more a year on the same number of patients. So yeah, there's ways and just to do the math and follow that out. But 30% would be on the upper end. You can get it to 20-25%, I think, if you're so inclined.
Okay. Well, Josh, you've given us a lot of your time and a lot of information. I'm so very thankful. You mentioned a service that you provide, your company provides docs that are interested in DPC. Can you please mention where they can access that?
Yeah, either our live chat, atlas.md. We have a Facebook page, AtlasMD support. My email, drjosh@atlas.md, no.com, or hello@atlas.md. Any way you reach us, everybody knows how to provide that information, get you started. And so if anyone's DPC curious or has questions or they're active in it, again, rising tides raise all ships. Will help anybody.
Awesome. Thank you so much again. Well, that's a wrap for today's episode of Finding Financial Freedom. A huge thank you to Dr. Josh Umbehr for joining us and sharing his incredible insights into direct primary care and physician empowerment. If you're inspired by Josh's journey and want to learn more about Atlas MD or DPC, check out atlas.md and imdirectcare.com. Don't forget to subscribe to the podcast and you never miss an episode. If you enjoyed this conversation, please leave a review. Until next time, stay frugal, y'all.
The content shared on this podcast should not be taken as individualized financial advice. We are here to share our knowledge and experiences, but it is crucial to consult with professionals such as accountants, financial advisors, or attorneys who can provide personalized guidance based on your specific needs.